Now I'd be talking
Thank you.
about the ocular surface lesions. Hello. Yeah. So I'll be talking about the ocular surface lesions. So when we want to talk, there is a wide array of pictures, atlas, and most of them you must have seen, and maybe diagnosed, maybe undiagnosed. The most important take home from my whole presentation should be that at the end of presentation, most of you should be able to diagnose which are the lesions which are easy, which are only good or bad, and that can be managed at everyone's level, and which are the ugly lesions which you need to refer. So this is one of my favorite slide where there are this lesion, they are almost similar looking to each other, and if they come separately, then we might diagnose everyone as a pterygium or some kind of inflammation. But when all of them are in front of you, then you know there is something different. So I will not increase the suspense beyond this. I will just tell you this is one is actinic keratosis, other is pseudoepitheliomatous hyperplasia, and third is OSSN. Now, whenever you get two similar lesions, the best way is try to talk about the lesion and describe the lesion. It will make your life easy. So whenever you want to find the difference between two similar pictures, go from left to right, and of course you'll find the difference. So let's begin our journey of identifying which are good lesions, which are bad, and which are ugly. So first we'll talk about the good lesion, and which is of course more compared to the rest of it. So when I show you this different kind of pigmented lesion, let's start with the most common one. A 17-year-old female comes to your OPD with this kind of a mass, and she has obvious complaints that it is increasing in size and it is also causing discoloration. So with what confidence you can tell her that this is just a nevus and you don't have to worry and this will not harm you anyway for your life? For that you need to see there is certain checklist which you should not miss at all in this kind of a lesion. So this appears first or the second decade of life, which is common. This is not congenital. This is majorly in the interpalpebral area. There are feeder vessel, there is intrinsic vascularization. It does grow. Nevus is not something that should be stable in size, and it will have a variable pigmentation. It will be light brown, dark brown to black to a certain extent. It will not be a single color. And sometimes when you cannot see the cyst properly, then you can of course do ASOC2 to ASOCT to document that there are cysts and it is not encroaching on the cornea. So these are very clear features which differentiate your nevus from anything else. Now since we have learned about nevus, let's put one more picture in front of you. Again, this is a 28-year-old male with good vision and coming with the same complaint that this mass is growing. Now let's dissect this mass properly, and we see this mass as a two component, one the upper component and one the lower component. We are not bothered about the upper because it is showing good features, it is showing cyst, everything, and it is falling in the diagnosis what we have seen in our last slide. Now what about this? When we are seeing this part is little not so nevus kind what we differentiated. So what is so much different than the nevus? So this is away from the limbus. Okay, this was not there in the checklist. This is involving caruncle, not in the checklist. Cysts are not seen here. The pigmentation is too much dark and the margins also are not very clear. Now we need to differentiate that are we looking at a good lesion or are we looking at the bad lesion? What do we do in such cases? Again, there is a simple checklist that which nevus you should excise and which nevus you can observe. So there are certain indications which are there, and let's have a checklist again. If there is a nevus without cyst, of course our lesion is without cyst, especially the near the caruncle one. Nevus which is more than 1 centimeter, of course our lesion is much larger than that. A lesion which is very much uniform dark pigmentation, it is showing that it is turning into a malignant one and it is involving cornea. So all these lesions, all these points tell that you need to excise this nevus. So we will excise this part of the nevus, did an incision biopsy, and that showed that this is turning out to be a melanoma. So nevus can turn out into a melanoma, and then we had to do excision biopsy, and go further. So any nevus you are observing, you need to be very careful and keep watching it and tell the patient. Most of the nevus patient will come to you with the cosmetic blemish, and of course for the cosmetic reason also you can remove the nevus. How many of you have seen this nevus very often in your OPD and excised as well? How many of you excised the nevus? Yeah, very much. And what was the indication? Cosmetic. Observation, correct. So the cosmetic is something that will come most often to you, but the size is something that you need to look after. Now coming to this lesion, again this looks quite a benign pigmented lesion, but this is not a conjunctival pigmentation, this is a UVL episcleral pigmentation, and this is nothing but what we call it as a congenital ocular melanosis. Why these lesions are important? Generally 2-3 year old patients might come to you with this kind of a lesion that there is some pigmentation happening. You need to dilate this patient once in a year to see the retina properly, because they 1 in a 400 have a risk of having a UVL mass in such cases. Of course, you do look for hairline pigmentation and palatal pigmentation, because this is a congenital mass and the pigmentation could be anywhere. Now, out of all the lesions that I am describing today, this is the most common, especially those who practice in the rural areas. You see this kind of a variable pigmentation around the limbus 360 degree, but this is something not to be worried about. Once you see this one eye, always see the other eye and you will have this a bilateral. The most important feature of differentiating complexion related conjunctival pigmentation, that it is a bilateral lesion. Now coming to next, what is it? Like I had shown this in a very first slide, this looks not so a healthy lesion, but this is just a reactive inflammatory proliferation. This is conjunctival pseudoepitheliomatous hyperplasia, more of a histopathological diagnosis than it sounds to be a clinical diagnosis. Why it happens? Generally secondary irritation could be because of some surface inflammation, some sutures post-pterygium surgery, some foreign body not completely removed. All this can cause hyperplasia of the epithelium. And how to treat? Again, a simple excision is the way to go in such cases. And run through few lesions which are not so common. These are inclusion cysts, especially in the fornical and the caruncle area. They have a high amount of vascularity, but they are very much benign and they can be easily excised. Now, what kind of lesion is this? This was one of the shown by Puneet. This is capillary hemangioma. Again, having a conjunctival hemangioma is rare. It generally comes from the orbit of the eyelid and then it comes to the surface. The propranolol is the way to treat. No, what is this happening? A cactus growing near Eiffel Tower? No, these are choriostomas, and 5 choriostomas which everyone must be aware of, and these are the pictures. I think most of them must be seen by you. The most common ones are the first and the third. Dermoid is what we see most commonly. Dermoid comes with the 3 different types, where it is either growing partially on the cornea or fully on the cornea, and the in-between variety. So these partial ones do encroach on the cornea, but there is only lamellar involvement of the cornea up to 100 to 200 microns. So they can be easily tackled without doing any lamellar keratoplasty, but don't be overzealous while dissecting it. Lipodermoid, again common, generally never comes into the site. The one important point when you're excising this kind of lipodermoid is be careful with the lateral rectus muscle. Secondly, don't be overzealous that I want to remove the whole of the fat and I will just make the patient fatless. That is not going to happen, because it is going to come from the orbit. So remove only what is necessary, and the rest you can just reconstruct putting the AMG there. Don't try to remove the whole of the fat from the lipodermoid. Others are rare, which is osseous choriostoma, complex choriostoma, and lacrimal gland choriostomas. All this we discussed were the good lesions. Now let's go to the bad ones. Now you see this kind of lesion very often, and like I told you, when you see this kind of a lesion, you need to see the other eye, but you will find the other eye may be normal. This was called as a PAM, primary acquired melanosis, which nowadays they call it as intraepithelial melanocytic proliferation. Again, a pathologist term. This generally manifests in the middle age, unilateral, superficial, solitary, patchy, diffuse, multifocal, and it could be anywhere on the conjunctiva. These are the lesions you need to be worried about. When do you need to worry about? These are the 4 conditions of the PAM you need to be worried about. First, it is growing more than 5 millimeter. Secondly, it is involving cornea. Thirdly, there is a history of melanoma anywhere else in the body, and you are seeing the patient over a years or years together, and you see that there is a pigmentation and increase in the mass. That is the time that you do a biopsy for the PAM to see that it is with the typical changes or not. Depends on that, the rest of the treatment goes on. Now this is again a very simple looking lesion. Many of the times we say write it as a pinguicula. Go ahead and put patient on the tear substitute. These are basically actinic keratosis. These are pre-malignant lesions. You need to observe if it comes with the recurrent inflammations to you. Otherwise, you can simply observe and keep the patient on the regular follow-up. Excising is not a difficult issue here. Now coming to the ugly lesions. Now you see this kind of a lesion. I had gave you the glimpse of the same when I was talking you about the nevus part. Your nevus, which is darkly pigmented, growing on the cornea, feeder vessel, crossing Earth's boundary, it is nothing but a conjunctival melanoma. Conjunctival melanoma, it is most commonly comes from your PAM. So whenever you are seeing PAM, do be suspicious about it growing into a melanoma. From the nevus, 20% of it, and 5% de novo. Older age, thicker base, no cyst, and the hemorrhage are most important things which will help you to differentiate your nevi lesion from your melanomas. Now again, the first slide I am showing you. When you see this kind of a picture, like I told you, you see a surface lesion or any lesion, try to describe. So I will describe it for you. Describe in terms of location and the growth. It is on the bulbar conjunctiva near the limbus, growing on the cornea. There are feeder vessel, there is a keratin, there is an intrinsic vascularity, and there is a rose Bengal staining. If you see a surface lesion, if you see a pterygium, and you have even a smallest of doubt that it is not fitting into what you see on daily OPDs, please think that this is not a pterygium and something else that you are looking at. And these are the 4 points which will help you to differentiate your pterygium from your OSSN. This is nothing but a ocular surface squamous neoplasia. How do you treat? There are various treatment options. Observation is out of box. Excision biopsy, chemotherapy, radiation, exenteration, all these are different features. Now I will not go into details of this. I will just show you in a brief. This is all 4 are ocular surface neoplasia, and all of them are treated, and these are post-treatment pictures. And these are the various way we treated them. The first is surgical, second is interferon, third is excision plus radiation, fourth is chemotherapy. So just briefly to tell you, the first lesion is very small, here it is, and this can be very well excised if you know the patient is not going to come to follow up. This is a very wide one which you cannot excise because the whole cornea is involved. Here giving a chemotherapy makes sense because it is involving more than 6 quadrants of your conjunctiva. This third nodular lesion has equal amount of the base, and this also involves your sclera. You cannot remove the whole sclera and do a scleral patch graft. Here your radiation comes into picture. And the fourth one, like I told you, can be treated completely with the interferon or 5-fluorouracil, whatever it is available in your town. So when we see that we know everything about OSSN, I would like to keep a picture in front of you that this is a patient getting treated with as scleritis, and patient is on steroids. There is no improvement, there is no pain, all the workup for collagen vascular disease is negative, and patient's lesion is keep growing. You see any kind of ocular surface lesion, again not fitting into a common diagnosis which has been made by your previous colleague. Very simple thing that you do in your OPD is please do stain the lesion. Again, this is a masquerades the way the OSSN can present. Other most important tool everyone has in their OPD is doing a ASOCT whenever you feel in a doubt of a diagnosis of OSSN before you go ahead with the biopsy. And the third ugly lesion, just to give you a brief history again, a 50-year-old female comes with this kind of a pinkish mass which is not again resolving, no pain, not fitting into a picture of scleritis. What are you looking at is a diffuse, slightly elevated pinkish mass is basically could be a conjunctival lymphoma. It could be unilateral, it could be bilateral, and there are high chances that this get converted into a systemic lymphoma. So you need to be very careful with such lesions. So these 3 ugly lesions you should be very aware about: melanoma, OSSN and lymphoma. Rest, most of you can manage at your level. So when you have a different lesion like this, You just use the algorithm that we just discussed, describe the lesion, try to fit into one of the diagnoses, and just classify that as either a good, a bad one, or the ugly one. So to conclude, examine every conjunctival lesion carefully, document it properly, keep a high index of suspicion, and biopsy when needed. Please do that. I acknowledge my mentor, Dr. Santosh Onava sir, for teaching me everything that we discuss here, and thank you all for patient listening.